I'm a physician scientist. My name is Irina Petrache, and I have the privilege of working at National Jewish Health for the past 1 year. Prior to that, I was a professor of medicine at Indiana University in Indianapolis, and I did my training at Johns Hopkins University in Baltimore. The accent is Romanian. So again, I'm thanking to all of you, to the sponsors, to the Alpha-1 Foundation, who has been a staunch supporter of our work and my career. So I'm a physician scientist, which means that I do a lot of research. About 80% of my time is spent in the lab, in research, leading a laboratory of scientists. And a large part of my lab is studying alpha-1 antitrypsin biology with the hope of finding a cure. The other 20% of my time is spent at bedside as well as in administration, and I do see patients with alpha-1 deficiency as well as non-alpha-1 COPDers. So it's again a privilege, and today I was tasked to just bringing again the basics of what we know about what is alpha-1 antitrypsin and how it can affect the liver and the lungs. So I call this Alpha-101. For some of you, this may be very rudimentary information, just a refresher, and for some of you it may be new. And I would like for this to be interactive, so if you need clarifications or have a question, please just raise your hand and I'll be very happy to stop and address it. So what do we know about alpha-1? What is alpha-1? Alpha-1 antitrypsin is a normal protein that our liver makes. So this is its crystallized structure. And it's called a glycoprotein because it has amino acids like every protein, and then it's coated with some sugars that play an important role, but we know very little about that. So we need to learn more about what the role of those sugars would be. So again, the liver is the main producer. Hepatocytes are liver cells, the main factories of proteins in our body. So it's not surprising that alpha-1 is made in the liver, given that's where all the major proteins are being made. There are minute levels of alpha-1 protein that are made by other cells in our body. For example, the corneal cells that line our eye, or the intestinal cells, or even the cells that line up the breathing tubes. And we focus most of our research and attention on the liver and the alpha-1 that's circulating from the liver. And we know, again, very little about the role of these local pools of alpha-1. That's an interesting thing to think about. Do they have a role? Do they cause any problems when the alpha-1 is abnormal? So the liver knows to make a lot more of alpha-1, tenfold more when the body is under stress. And stress can mean an infection, it can mean pregnancy, it can mean a burn, or any other major stress. And there's a handful of proteins that belong to this category of kind of like our emergency pool of proteins. If something goes wrong, the liver gets a signal of alert and it dumps this set of proteins into the bloodstream. And we think that that's important to fight the stress. So this surge of alpha-1 antitrypsin in our bloodstream, we think it's very important to fight that stress. And how does this apply to those who don't have the ability to make this normal alpha-1 during stress? Is that it may make those individuals more prone to be more susceptible, more prone to get that infection, to not get rid of it of a cold in 1 day or 3 days, but to have it go on for weeks or months. So their susceptibility to any stress may be much higher. So the other important thing to know about the alpha-1 is that It's a anti-protease. So what it does, it's kind of the antidote of enzymes that chew up other proteins. So a protease means an enzyme that chews up proteins. An anti-protease, which is what alpha-1 is another protein that can neutralize, can inhibit that ability of the protease to chew up proteins. So the main affinity of the alpha-1 for these proteases is against elastase. Elastase is made by white blood cells. A lot of it is made by white blood cells. So white blood cells release elastase to kill bacteria, to fight infection. So elastase is good, but it's always a balance. Alpha-1 antitrypsin, made by the liver, as I mentioned, is supposed to bind and keep it under control, keep it under check. When we have less of this alpha-1 antitrypsin, there's much more elastase available to do more than kill the bacteria and actually start to attack our own tissue. And I'll show more about that in a second slide. More recently, we and other laboratories have identified other proteases that are being attacked by alpha-1. And these proteases have roles in modifying how we react to all kinds of stresses, not only infection. So we and others have identified that alpha-1 also modulates how our immune system works in general. So not only infections, not only elastase, but also how we deal with immune problems in general. And that's why we think that folks who have alpha-1 antitrypsin deficiency are more prone to autoimmune diseases. For example, we recently learned about diabetes being one part of the autoimmune disease that alpha-1s may be more prone to, or that paniculitis or vasculitis, which is inflammation of the small vessels. It is because alpha-1 is supposed to keep the immune system under check. So these are the basal functions of the alpha-1 protein at a cellular and biochemical level. So let's learn more about this whole circulation and how we now understand the disease develops. So this is in normal situations. So in normal situations, this is the liver, and these are the liver cells, those hepatocytes, and they surround the blood vessel. So they make like a factory the normal proteins that are then exported out of the cell into the bloodstream, where they circulate and bathe our whole organism. So normally we have these levels of alpha-1 antitrypsin circulating in our bloodstream. So as I mentioned to you, these are the vessels that surround, now we are in the lung, surround the lung airspace. This is an alveolus, a cartoon of an alveolus. The alveolus is kept nice and open for air to come in and get the oxygen into the bloodstream by these elastic fibers. So when we see bacteria or there's smoke or any pollution, any type of stress on the lung sends these neutrophils, the white blood cells. They are like soldiers, as well as some station soldiers, which are macrophages. And these guys are meant to protect us, and they're going to send these proteases into the lung. So alpha-1 antitrypsin is supposed to neutralize some of the proteases, especially if they come up around this blood vessel, because they are supposed to stay here in the airspace and fight. So when one has alpha-1, that is being neutralized. You can't come in here. When one does not have enough alpha-1, then these proteases chew up the elastic fibers and the lung gets collapsible. The lung loses these structures. These cells are starting to die, and holes are formed in the lung, causing emphysema. So what happens in those who have alpha-1 antitrypsin deficiency is that they have a mutation in the gene that makes alpha-1 antitrypsin. So you're all familiar with the MM and the ZZ. So normally, normal genes are called MM, and when there's a mutation, the most common mutation is called the PiZ mutation. So the way this is transmitted genetically from parents to children is called an autosomal codominant inheritance. So what does it mean, codominant inheritance? So we all have two alleles of the gene. And in this case, if the parent is a carrier of an MZ allele and the other parent is also a carrier of the MZ allele, codominant means that each allele, each DNA strand is gonna make the protein that it encodes. So this person will make an M protein and a Z protein. So both these genes on the two strands of DNA are active and are going to have a say. There are some diseases in which one of the alleles is silent and doesn't say anything. Or there are other genetic diseases like Huntington's, for example, that are autosomal dominant diseases where even if you make only one, only the disease allele is going to have a say. So in this case, in the alpha-1 gene, it's a codominant disease in which each strand of the DNA will produce the protein. So a carrier will have some M and some Z protein. So some of the alpha-1 is normal, not mutated, and some of the alpha-1 is mutated, is Z, and can make polymers. More about that later. So this is the risk of the offsprings in this particular genetic disease of either becoming carriers, so there's a 50% chance that the offspring will be a carrier. There's a 25% that the offspring is going to have the full ZZ mutated protein and be at the highest risk of disease. And there's a 25% that the offspring will have normal genes. So what happens if one has the mutated protein? So as I mentioned, the mutation is in the gene. It's in the genetic coding DNA. And that gene is then being transcribed into a messenger RNA that will carry that message from the gene into the factory that makes protein in our cells, in the cell of the liver. So this message is being then transcribed into a protein message. And that's sort of the MM protein. Then sugars are being added. Remember, I told you that this protein needs sugars. And that allows it to be exported into the bloodstream. So everything, the protein is folded normally, gets out in the bloodstream where it does its job. So this is during normal conditions. During what happens when the gene has a mutation, the ZZ mutation, is that that defective code is being transcribed, it's being carried by the mRNA, and then that gets into where the protein is being translated, and it carries this mutation. So the protein is mutated, and unfortunately, because of this mutation, it's folded differently. So that's the major problem with the mutation, the ZZ mutation, is that the protein kind of folds upon itself. Instead of being nicely malleable, flexible, and getting out of the cell, it kind of gets folded upon itself. So it's a folding problem and a polymerization problem that we'll hear when we talk about drug development. So this abnormal protein, even though it has only one amino acid that is wrong, but that amino acid is enough to make the protein crooked. And that crookedness allows it to fold upon itself and form this chock hole of polymers. So they cannot get out of the cell, or very few can. It's never a black and white thing. It's always some get out, some stay in the cell. So the liver problem happens because the liver cells get choked with these large amounts of crooked protein called polymers. So that can put the cell under stress, and instead of minding its own business of being a factory of proteins that are useful for us, the liver makes antibodies that fight infection, make coagulation protein that stop bleeding. So now it's under stress. It's like danger zone. So it stops proliferating. So you know how liver regenerates very easily because it has this, it's a very active cell that can make more cells, etc. But in this case, it can't because it has to handle this stress. And sometimes it handles it very well. And that's why many people are without symptoms for a very long time. But many times it cannot cope with the stress and the cells start to die or not make the other proteins that are supposed to be made. You can imagine during stress when the liver is meant to send out tenfold more alpha-1, it can't. So a lot of the problems with alpha-1 are due to this decreased secretion into the bloodstream. So that's why alpha-1 genetic mutation is called alpha-1 deficiency. The majority of individuals who have ZZ, they make alpha-1, but the deficiency is in the circulating alpha-1 in the bloodstream. And these are the levels of alpha-1 that we can measure in the bloodstream. Percentage of normal, and I gave you the normal values in an earlier slide. So you can see that with each of these mutations, MS and going down to ZZ, there's less and less protein that is being circulating, dumped by the liver into the bloodstream. And the worst case scenario of deficiency, and this is a true deficiency because the cell just doesn't make any alpha-1, the gene doesn't know to even send out a protein, is the null case. And those folks have the most severe lung disease, but they don't have any liver disease because there is no alpha-1 to mess up the liver cells. So the liver disease, as far as we understand after decades and decades of research, is solely due to the fact that the abnormal protein is stuck in the liver cells. So if you don't have the protein, you cannot have liver disease. But if you don't have the protein, the lungs tend to be the most susceptible to the stresses, and those individuals are at the highest risk for emphysema or damage of the lung. We'll talk more about the MZs, the carriers. That's a very active area of research, a little bit neglected in the past because most carriers were not that symptomatic, so we kind of had to put the fire out first and focused on the most severely affected individuals. But now we're learning more and more about the carriers, and I have a little bit about that in a minute. So again, this is what happens to the liver. Many individuals can cope with the polymerized protein in their liver cells. But if they can't, this is what can happen. Early, when the child is born, a lot of infants have, or newborns have jaundice. if the infant has too much jaundice or the jaundice is too prolonged compared to that more physiological, early, lazy liver type of a problem, then alpha-1 should come to mind of the doctors. There is alpha-1 deficiency that affects the liver is one of the most common causes of liver failure in infants. So they cannot cope, and the liver gets sicker and sicker, the cells die, then the liver shrinks and fibrosis. So the cure for that is a liver transplant. And again, that's one of the most common causes of liver transplant in young children. However, we do see liver disease creep up in the adult life. And when that happens and in who that happens, I have a few words about that on this slide. So typically it will happen in someone who survived the lung problems. So an elderly individual who did not have a severe lung disease has coped with the lung for a long time, more frequently in males, and their liver enzymes can start to go up. Could it be because the liver is exhausted in coping with this for years and years and years, and that's why we're seeing late? That's possible. And then we also have this double or triple whammy situation where, again, the liver cell is very busy to cope. So if you add a second stress and a third stress, you make it even harder. So what are those stresses that we need to avoid? Obviously, alcohol makes the liver stressed. Any toxic medications that are known to affect the liver, a lot of Tylenol use in mice. It's been shown recently that they don't do well with even ibuprofen or Advil type of a medication. So again, if we can be as ginger as we can with the liver of ZZ individuals, as well as MZs, I would add, I think the better. The nulls, don't need to worry about it, okay? So whenever we think liver and liver disease, most folks, when they diagnose liver disease, want to do a biopsy, a needle across the abdomen to take out some of the liver, put it on a slide, and look under the microscope. We don't recommend that. It's not needed for the alpha-1 disease. It's typically needed if you think there's something else going on. But the first test that should be done is a blood test to confirm or rule out alpha-1 deficiency. If alpha-1 deficiency is ruled out, then of course a biopsy can be considered. But if alpha-1 deficiency is confirmed, a biopsy is not needed, and that can save you from a lot of aggravation. So the only time when you do, when a liver biopsy is reasonable is in those who have a confirmed liver disease for a long time and things are not getting better. So you want to stage to see how severe that fibrosis, that shrinking is. And in that situation, a biopsy is reasonable after other non-invasive tests have been exhausted. And that can help the doctors tell you when you should be ready for a transplant or not. So what I meant to say with this slide is that the cirrhosis and the liver problems in alpha-1 deficiencies are no different than in those without alpha-1 deficiency. So there's nothing special about having alpha-1 and having the liver disease, except that's the cause of your liver disease. Everything else is the same as with other patients with cirrhosis. And why is this important? Because a lot of physicians are intimidated when they see a rare disease, or they say, oh, you have alpha-1 and liver disease, what am I going to do? But actually, everything that a physician does about any cirrhosis will apply to those with alpha-1. So the same precautions, the same vaccinations, the same follow-up, the same testing is applicable. So that should, you know, help your physicians be more comfortable with managing you, as well as allow you to do your own research about what's new in how to manage liver disease, because you can explore the literature, the knowledge from just run-of-the-mill cirrhosis. So probably 100-fold more investigators study cirrhosis from obesity or alcohol abuse than they study cirrhosis from alpha-1. And that's okay, because, in a way, because you can learn from that knowledge to manage the disease of alpha-1. However, what is specific about alpha-1 is hopefully in the future we can prevent the liver disease from happening by stopping this production of polymers, or finding a way to chew up the polymers in the liver to help the liver cope with them. And again, finding ways to protect the cells so they can handle the stress longer. So all these are approaches that are now in various stages of investigation or clinical trials. One of them is a silencing RNA there's a trial that National Jewish Health participates in. So the treatment of alpha-1 liver disease, as I mentioned, a lot of prevention of the double, triple whammies. I think this is the time to invest in non-alcoholic beer and non-alcoholic apple cider, and just forget about alcohol. And I think alpha-1 individuals are very good at really being disciplined and protecting themselves. They have a much higher rate of quitting smoking than any other COPDers, that is really important. That's why it's important to know you have alpha-1, because then you can do all these prevention stuff. Avoiding exposure to any hepatitis if you can, and getting vaccinated is equally important. And as I said, just surveillance of your liver with imaging is also indicated. So what about the lung? So typically the lung disease happens because of these low levels of alpha-1 that are protecting our alveoli. But we know that a lot of other things weaken the alpha-1 protection of the lung. And the most important is smoking. That's what this oxidation means. So smoking or a lot of pollution can make even the normal alpha-1 impaired in its ability to fight the other proteases. I mentioned about some of these polymers getting out of the liver, making it out of the liver. There's a lot of research now that maybe these polymers are in and of themselves harmful because they tickle the lung in a negative way. They induce more inflammation by themselves. So again, trying new therapies to try to get rid of these polymers is now under consideration. So all these sort of multiple mechanisms eventually lead to this destruction of the lungs. And these are the lungs, obviously, this is the heart. And normally the lungs should have this kind of gray opacity on the X-ray, on a regular X-ray. And you see how there's less gray in here, more black. That's a lot more air, that there's no alveoli to keep it there and cause that gray area. So the tissue is lost, and you have these larger air spaces that you lose the surface to exchange oxygen, get the oxygen into your blood. And that is what emphysema is, a loss of alveoli, of tissue that's meant, this is what the lung is meant to do, to exchange the oxygen and get it into the bloodstream and get the carbon dioxide from the bloodstream and put it into the air. So to do that function, you need a very thin membrane to get a gas from the air into the blood. Very, very thin membrane. And this is what the alveoli are. They're very thin membranes that are also very susceptible to harm because they are so thin. So the rest of the lung is more like an air filter to protect these alveoli from damage. It's okay, we'll be fine. I don't want you to fall asleep. So I think it's important to understand this because this is how you can think about protecting your alveoli. So the alveoli are meant to be protected by alpha-1 antitrypsin. If your alpha-1 antitrypsin is not there to protect it, then what else can you do to protect your alveoli? And as I mentioned, the airways, that upside down tree that branches out is actually a big air filter. And it's meant to clean the air, so by the time it gets to the alveoli, it's as clean as possible, and most of it has just oxygen and nitrogen, so you can exchange that. So avoiding pollution is very important. Avoiding smoke exposure, first-hand, second-hand, third-hand smoke exposure is very important because your other line of defense is gone, so that's all you can do. More about that in a second. So what are the typical manifestations of lung disease? Typically an earlier onset of lung problems. Many folks have a history of coughing earlier, not getting rid of infections soon enough, maybe a diagnosis of asthma early on. And these are the sort of classical things that you saw in that video that are supposed to like light a bulb in the head of the physician. But you'd be surprised that there are several myths that make physicians light their bulb only if they see classical signs, but nobody is textbook medicine. There are a few people who are textbook medicine, but many of us present in different ways, and that's what makes physicians miss this diagnosis. If you are not a textbook case, then, or if the physician doesn't read the textbook, then that's a problem as well. So classical, this unexplained liver disease. I'm going to talk about panniculitis just briefly. This is a case of panniculitis. So it's this inflammation of the soft tissue, of the fat tissue under your skin, and it can have ulcerations or just induration or pain, and it's thought to be due to the small blood vessels being affected, being unprotected by this alpha-1, being prone to immune craziness. So the other part is that I wanted to emphasize is bronchiectasis, especially in a clinic like at National Jewish, where we see a lot of more difficult, more unusual cases. We see that a lot of folks with alpha-1 have this bronchiectasis. So what bronchiectasis is that this air filter going through the bronchi. The bronchi are supposed to taper and become thinner and thinner as they branch. In bronchiectasis, because of inflammation of the walls of these airways, they become more swollen, more enlarged. So instead of tapering, they stay straight on the X-ray or on the CAT scan, or they sometimes even become more like grapes, so they enlarge instead of tapering. So what happens, why do we care about that, is that the enlarged bronchi start to pool the mucus. Mucus, we all have mucus, it's supposed to help the filter. It clears things. It traps, like you have that sticky stuff that traps the flies. Then you have the cilia that are like elevators, so you can cough that stuff up. So in bronchiectasis, you lose some of that filter function. So the mucus becomes pooled. There's no more elevator function because the cilia are damaged by inflammation. So guess what likes to hide in dark, wet places, mucousy places? Bacteria and fungi. They love it. There's like caveman situation. And they start proliferating, and you form that mucus that you cough up in the morning because you pull all that stuff. Then when you wake up, gravity may bring it up. So a lot of folks with bronchiectasis, what they have is early morning toilet of their airway. So you cough up all this gunk that's yellow, green, all shades, and it's the accumulation overnight. So that's a clue that you might have bronchiectasis, is that morning chock full of phlegm that then gets better during the day, and then you start again. So why is it important to know that you have bronchiectasis? Is because there are certain treatments that are specific to bronchiectasis. There's no cure, but there are ways to manage it so that you don't have it get infected too much and get into trouble with it, with exacerbations. So a little bit about the prevalence, just so we all know that you're not alone. It's a very common disease. It's throughout the world. There's another preconception that some physicians have, that it only happens in white of European descent, and it's not true. It's everywhere. Some of the places it's just not tested, and we need to do a better job to carry our message and knowledge to third world countries that have folks who die prematurely because they don't know about it. So it's the typical image of the iceberg, more testing. I just wanted to mention that just a month ago, I have diagnosed with ZZ an individual in her 60s, and she only smoked for 15 years and had very severe emphysema. Otherwise, healthy as, healthy and active and very functional, and nobody has thought about this. She had a chronic cough, and that's it. And then for some routine reason, an X-ray was done and emphysema was diagnosed, but nobody tested her for Alpha-1, which is a shame. So even in the United States, even in Denver, this happens. So you can imagine once you go outside beltways, what the situation is. So this is the data, right? Half of you have had to see at least 3 doctors to get the diagnosis. And I'm not proud for my profession to show this, but this is the reality, and we need, that's why all these campaigns of bringing awareness are so important. If you don't know it, you don't know how to protect yourself. You're gonna continue to work in that industry that will expose you to dust. You'll continue to smoke, you'll continue to tolerate a spouse who's smoking, but if you know you have it, you're gonna take steps and you're gonna test your family. So again, COPDers have to be tested, or asthma who doesn't get completely normal in their lung function in between episodes, asthma has to be tested as well. So again, this myth that patients are too old is totally false. You can see it's a kind of a normal distribution. The majority are diagnosed in the middle age, but you can go in the extreme ages as well. So again, the smoking, if you don't smoke, we're not thinking about it. There are 17% of the folks who have never smoked. And as I mentioned, very good job in quitting smoking, which is one of the hardest things that addicted people have to do. It's worse than quitting hard drugs. But once you know you have it, people are very committed, and kudos to you. So again, airway inflammation, this filter issue, we're not only seeing that alpha-1 predisposes to lose the alveoli, but we're seeing these airway problems as well. 40% have bronchiectasis, and that, again, MZs tend to have that predisposition, as asthma and chronic bronchitis. So some alphas obviously are asymptomatic, and when I gave my first presentation to a small group of alphas in Indiana, I was corrected, and I really appreciated that by some of your friends and or family that have said you should not refer to alphas as patients. We are not all patients. Some of us are asymptomatic, and we don't want to carry the label of being patients. And I really appreciated that, and I'm trying to educate my colleagues to be sensitive about that notion, that some of you are carriers, some of you are ZZs and are not symptomatic, and you're just individuals who carry on with their normal lives. So the lung disease in carriers, I wanted to spend a minute, and I know I'm running out of time, which I also am notorious for, that we're learning more that MZs, because of that half a gene, half of allele, half of the DNA that produces the abnormal protein, the MZs are susceptible to lung disease, and we have to keep an eye on the levels, on their lung function, especially emphysema, lung function, and bronchiectasis symptoms. And also liver disease. We need to monitor the liver function test, to think about vaccination against hepatitis B, avoidance of blood products if possible to avoid the risk of hepatitis C. So again, it's not that M is going to take care of business, and we need to do more work on that. So this is a slide that I would like those who have ZZ or even MZ or other mutations to remember, that we're just now beginning to learn about why other illnesses are creeping up in those who are having MZ or ZZ or other more rare mutations. And I cannot pretend to have the answer as to why this is happening, but I think it's very important to study. And there is a susceptibility to non-tuberculosis mycobacteria, or NTM, and if you don't test for that in the sputum, you're never gonna find it. So if you are affected, if you have this sort of chronic bronchitis or small mild pneumonia that never goes away, and you're exhausted and with fevers, etc., then this is something that your doctors have to think about and do a special culture for it, because it's not coming in regular cultures. And then all these other autoimmune or immunologically associated illnesses, we're seeing them in alphas. So finally, you all know about testing, so I'm not going to spend a lot of time on this. There can be both level phenotyping and genotyping done. Genotyping is important when things are not so clear on the phenotyping, and we look for rare alleles, mutations. And again, avoid risk factors, and consider having your relatives tested for these reasons, to catch it early, to think about it, to be preventative. So finally, a few words about Alpha-1 augmentation therapy. It's part of a large portfolio of therapies that are classically used for all folks with COPD or chronic bronchitis or lung disease. This is the only thing extra. And who gets it and why get it and how often? Right now, this is the classical administration of a weekly dose. There are trials to find out if doubling the dose will help. I'm not aware of those results yet. And why get it? Why go through that pain of a weekly IV injection? Because more and more studies are showing a benefit of improving lung function, preserving that density. I've shown you the opacity on the X-ray. If you do that CAT scan, that is more sensitive. It's looking in more detail at the alveoli. So studies have measured how much alveoli you have based on that CT, and they've shown that if you take the Alpha-1 augmentation therapy, you preserve that. You lose less of that lung over time. And there's this decrease in exacerbations. And even after lung transplant, there's a recommendation that if one has the stress of an exacerbation of an acute infection because the liver is not able to dump that extra Alpha-1, maybe it's a good thing to get it. So the folks in studies that have benefited the most have been those with moderate lung dysfunction. But it's a very individual decision between you and your doctor. And this is by no means cut in stone, and there are more trials to come that may challenge this notion. But just I wanted you to know what's out there. So in summary, common everywhere in the world, underdiagnosed. Not a good idea to keep it under the rug for a long time. And it's a good idea to treat when you meet the indications. And we do need to do more research, and I'm so appreciative for those of you who are supporting research, either with your volunteer time, with your resources, or with your body, giving us samples and participating in registries, participating in clinical trials is just amazing. And many of you have to become really like a guinea pig in a way, where you get prodded and poked and bronchoscoped and everything, and that can be really painful. And being sick and having to do that, it's so generous, and I thank you for that. And if you would like to come to National Jewish, this is how it looks at night. We are not there at night. And and that was supposed to be in a different color. So we take phone call referrals as well as by email at referrals@national. You'll find.